Hello, this is ECG case of the week from Fox Terrier. Look at this ECG, press pause and try to make a conclusion in comments. In the end of this video we will describe the electrophysiological mechanism of this disorder. As you see, this is not full ECG, this example of Holter monitoring. Holter monitoring means recording of full ECG or some certain leads during some period of time from 24 hours to 7 days. It can be useful especially for detection of intermittent rhythm disorder. But 3-lead strip has some limitations. For example, we can't normally examine the mean QRS axis. Let's go to explanation. The first question for this ECG is who is the pacemaker of the heart, sinus node or not sinus. For this we need to find P wave. There are no P wave in any leads that we have. According to this, rhythm is not sinus. The next question is, does the rhythm regular or not? For this step, we need to check values of RR intervals and compare it to each other. The maximal RR interval is 12 large boxes, or 1.2 seconds. The minimal RR interval is equal 7 large boxes, and 2 small boxes, or 0.74 seconds. Now we need to find differences between these RR intervals in seconds. Let's make a proportion. 1.2 second is 100%. 0.74 second is X. X is equals 61%. So differences is 38%, which is more than 10%. It means rhythm is irregular. The next step is heart rate calculation. For this we need 60 divided to the RR intervals in second, but in case of irregular heart rate it should be calculated for minimal RR interval and for maximal RR interval. Heart rate should be represented in range from minimal to maximal. The maximal RR interval is 1.2 seconds. So the heart rate for this part, 15 beats per minute. The minimal RR interval is 0.74 seconds. So the heart rate for this part of ECG, 81 beats per minute. As a result, the heart rate range from the 50 to 81 beats per minute. The next step should be mean QRS axis calculation, but we have only 3 leads, therefore mean QRS axis can be measured properly. After this, we check all wave segments and intervals. There are no P wave and there are no isoelectric line. But instead of P wave, we have a lot of little deflections. All of these deflections have a different morphology and duration. These waves are F waves. Let's check the rate of these waves. For this, firstly measure the intervals between F waves. The interval is equal 0.1 second. And now we need 60 divided to this interval in seconds. The rate of F waves is 600 beats per minute. Absence of P wave, presence of F waves with very fast rate. Irregular ventricular rate. This is criteria of atrial fibrillation. Atrial fibrillation is a supraventricular tachyarrhythmia with uncoordinated atrial electrical activation and consequently ineffective atrial contraction. So why it is occur? For understanding the arising and maintaining of atrial fibrillation, we need to describe two things. The first one is driver. Driver is a small region in atria that can initiate the impulses at rapid rate that cause the atria to fibrillate. Driver always has the highest frequency of electrical activity. An important location of driver is the posterior left atrium around any of the 4 pulmonary vein atrial junction, or in the atrial muscles that extend into and line the pulmonary veins. The main mechanism of rapid focal driver activity are re-entry in small circles, early after depolarization, and delayed after depolarization. If you want more distinct explanation of this mechanism, let me know in comments. The second thing is substrate. Substrate is a mass of right and left atrial muscular tissue that can conduct fibrillatory impulses from the driver. Impulses that rise in driver go in disorganized pattern in substrate, this phenomenon called fibrillatory conduction. For fibrillatory conduction from driver to substrate, substrate should have a heterogeneity of tissue. Heterogeneity of tissue is regional differences in refractory period and conduction properties. Normally, action potential in different regions of the atria have a different time for repolarization that cause the differences in refractory periods, but it is not causes the atrial fibrillation. Only when the natural heterogeneities are enhanced by electrophysiological and structural remodeling, it can cause the atrial fibrillation. Electrophysiological remodeling means remodeling of calcium and potassium channels. Electrical remodeling leads to decrease in calcium currents inside the cell and increase in potassium currents outside the cell. That makes the refractory period short, therefore more vulnerable for fast driver impulses. Structural remodeling causes by fibrosis formation inside the atria and enlargement of the atria that leads to partial conductional block in atria tissue. Both electrical and structural remodeling can lead to circulation of impulses in atria, which forms the micro-reentry circles that maintain the atrial fibrillation. This circulation of impulses lead to rapid uncoordinated contraction of different atria fibers, which we see as F waves. Multiple impulses from atria suppress the sinus node because of their higher frequency. According to this, on ECG there are no P wave. Also, multiple impulses from atria bombard the AV node at higher frequencies that can be conducted to the ventricles. Concealed conduction and block in AV node lead to the irregular ventricular rate with normal QRS in absence of ventricular conduction system disease. Ventricular rate usually is less than 120 beats per minute under resting condition, but it can be faster during sympathetic activation that shortens the AV nodal refractory period, or slower during parasympathetic activation that lengthens the AV nodal refractory period. Let's check the criteria of atrial fibrillation according to ASC guideline. Irregularly irregular RR intervals when atrioventricular conduction is not impaired. Absence of distant repeating P waves and irregular atrial activations. If you like the content, press like and subscriptions button. Have a good day.
Here we go.